The rotator cuff is a cuff of tissue that surrounds the upper arm bone on the front, side, and back. This is a plastic model of the shoulder. It shows the ball and socket joint. Surrounding that is the rotator cuff, made up of 4 distinct muscles, but actually they all blend together into one single cuff. The biceps tendon coming off the biceps muscle, not shown here, actually dives through a groove and attaches to the top of the cup in the ball and socket joint. Over top of the rotator cuff is this little shelf of bone formed by a process that comes off the shoulder blade called the acromion, and of course the collarbone's right here. So patients who have rotator cuff symptoms typically present with pain in the shoulder, pain that radiates down the point of the arm towards the deltoid. They often have pain at night that wakes them up at night. They have difficulty reaching up overhead, stiffness reaching back behind them. A lot of the ladies can't fasten their own bra behind them, and the men can't get to the wallet in the back pocket. So you never want to go to lunch with someone who has a rotator cuff tear because they won't be able to pay. Those constellation of symptoms are fairly typical. When we meet a patient with those symptoms, unless they have an obvious complete cuff tear on physical exam, which is not always easy to pick up on physical exam, we treat them as if they don't have a tear by offering steroid shot, physical therapy, and anti-inflammatories. And with all patients who present with those constellation of symptoms, we're able to cure about 80 to 85% of people without surgery. So the fact that you have shoulder pain doesn't necessarily mean you're going to get an operation. For those that don't go on to a good result with conservative measures, we then image the rotator cuff to see if there is a tear inside that we're missing. The rotator cuff will show up on MRI, not so much on plain x-rays because it's a soft tissue. If the rotator cuff is torn, typically this top muscle, the supraspinatus, is torn away from where it attaches to the bone. And that's what causes the pain and weakness and radiating pain down to the shoulder. If that's torn and symptomatic, then the only option is to fix it surgically. We used to fix all these with an open cut on the skin, take off the deltoid muscle, peel that back, and work through an open incision. Now I do about 95% of my rotator cuff repairs arthroscopically. That just means through tiny poke holes. We use a TV camera, fiber optic lighting, and instrumentation, and operate in the shoulder while looking up on a TV screen, and we're able to do it all indirectly through poke holes around the shoulder. There's different techniques for repairing the cuff. The technique I use is to scuff up the bone so that it'll heal properly, bring the tendon back down to the bone, and fix it with something we call suture anchors. Suture anchors are just that. They anchor suture to the bone, so it fixes the stitches to the bone, which we can then, with the instruments I was describing before, bring the threads up through the rotator cuff and sew them down to the bone. The stitches kind of act like a cast. When you break your bone and put a cast on, the cast doesn't cure the broken bone. It just holds it in place until your body heals it. The same is true of the stitches. The stitches help hold that tendon in place while it heals. Everything in orthopedics takes about 6 weeks to heal, so it takes about 6 weeks for that tendon to heal down to bone. After surgery, we want to accomplish 2 things which are really at odds with each other. We want to gently move the arm so it doesn't get stiff, but we also want to protect the repair so it doesn't pull apart. We now use a device called a continuous passive motion machine. It's a mechanized chair that a company called Kinex can deliver to your house. And the patient after surgery, the day after surgery, can put their operated arm in this little cradle, and the robotic arm of the chair can gently move the arm to avoid stiffness without the patient moving it themselves, which would put the repair we just completed at risk. So that's a great advantage. People who use the chair use less pain medicine than those that don't. They have less pain and they get their motion back faster. So if it's possible for you to use the chair, I'd recommend it to you. Everyone that I've sent for the chair that have a secondary insurance, they're covered completely. And other insurances will cover the majority of it. We can put through the paperwork and see if your insurance will cover it or not. Whether you get the chair or not doesn't really matter in the long run. because people who have the chair and don't have the chair will still have the same result with successful alleviating of pain, restoration of motion and strength. But if you get the chair, it makes the whole early experience more comfortable. Where they were before was a painful shoulder they couldn't use, and so we make them a lot better than that. You know, the surgery doesn't make their shoulder 20 years old again, but it gets rid of the pain and restores motion and strength very effectively. I would just like to say that where we're at right now at Cleveland Regional Medical Center with rotator cuff repair is we're offering everything that's available in the medical science for rotator cuff repair. There's not anything that they're doing at the Mayo Clinic or up in New York that we're not doing here. So patients need to know and feel assured that if they do the program like I describe with the regional block, potentially solely regional block for shoulder surgery, they get the arthroscopic repair. We use suture anchors, and the technique I use uses a double row technique, which seems to be a bit stouter and a slightly higher chance of healing than a single row technique. The anchors I use also have no knots in them that can rub on the cuff after the surgery. If they get the CPM machine after surgery, that's as good as orthopedic science has to offer for rotator cuff repairs. And we're offering it right here at Cleveland Regional. So I'm proud of that and happy to be part of it.